Good afternoon, everyone. Thank you so much for joining us today at this really interesting webinar. I'm very excited to be here with two leaders in the field of public health, etc., more than just public health work. My name is Diana Romero. I'm a faculty member here, professor in our Department of Community Health and Social Sciences here at the CUNY Graduate School of Public Health and Health Policy. We are going to discuss for the next 90 minutes, I think, not only a really important and interesting topic from a historical perspective, but also given the world we live in today, the public health issues that we're confronting, the importance of sexual and reproductive health and justice, and ever, changing context just in this country and in the world. I can't imagine a more important and interesting topic to be discussing at this moment. I will now turn to introducing our two featured guests. On my far left is Dr. Machelle Allen. She is Senior Vice President and Chief Medical Officer of NYC Health and Hospitals, the public hospital system here in New York City. And certainly a true veteran of the healthcare system. She completed her residency in obstetrics and gynecology at NYC H&H's Jacobi Hospital, was an attending physician at both Harlem Hospital and Bellevue Hospital, became Associate Medical Director at Bellevue, then system-wide Deputy Chief Medical Officer, followed by, CMO, Chief Medical Officer in 2017. Dr. Allen has devoted her career to serving marginalized and underserved patients. Her early career was devoted to women who suffered from addiction or were at risk for HIV infection during pregnancy. And women's health and birth outcomes have remained an incredibly important passion of hers. As CMO, Dr. Allen has developed and implemented several system-wide clinical initiatives, too many really to go into at this moment. But one such initiative was in response to the mental health crisis resulting from the COVID-19 pandemic, called the Be Heard Program, or Behavioral Health Emergency Assistance Response Division, which deploys, and hear this, social workers with EMS personnel as first responders, as opposed to or in lieu of police officers. So we can imagine what an incredible public health intervention that is. With the goal of decreasing maternal morbidity and mortality, Dr. Allen and colleagues also created a system-wide Office of Women's Health Services, under which the NYC H&H Maternal Home was born, one of few in New York State. The Office of Women's Health has partnered with the Office of Behavioral Health to develop a substance use disorder treatment program for pregnant women and their families, realizing that substance use disorder impacts entire families and across generations, including partners, children, grandparents, and others. We're very pleased to welcome Dr. Allen to the CUNY School of Public Health.
Thank you very much.
My other super exciting guest is actually one of our own. Dean Terry McGovern is Professor and Senior Associate Dean for Academic and Student Affairs here at the CUNY School of Public Health. Dean McGovern is a human rights lawyer, advocate, and academic who is internationally recognized for her work in health and human rights, sexual and reproductive rights and health, gender justice, and environmental justice. In 1989, Dean McGovern founded the HIV Law Project, where she served as executive director for a decade. While there, she successfully litigated numerous cases against federal, state, and local governments. One such case, which we will hear about more so, was SPV Sullivan, which forced the Social Security Administration to expand HIV-related disability criteria so that women and low-income individuals could qualify for Medicaid and Social Security benefits. We may take that for granted now, but I think we're going to learn a lot about what that landmark case meant. Another landmark case was TNV FDA, Food and Drug Administration, which eliminated a 1977 FDA guideline banning women of childbearing potential from early phases of clinical trials. She then served as Senior Program Officer in the Gender Rights and Equality Unit of the Ford Foundation, where she oversaw global and domestic programming relating to HIV, gender, LGBT, and human rights. This was followed by her appointment as the Harriet and Robert H. Heilbrunn Professor and Chair of the Heilbrunn Department of Population and Family Health at Columbia University's Mailman School of Public Health. Dean McGovern is a member of the Council on Foreign Relations, the UNFPA Global Advisory Council, and was lead author of the 2022 report of the High-Level Commission on the Nairobi Summit on ICPD 25 follow-up. I'm very pleased to call Dean McGovern my colleague here at CUNY SPH. So now with that said, maybe I should just say a little more about why I'm sitting here with these two folks.
Please do.
Pay tribute to you. In addition to being a very really happy faculty member in community health and social sciences here at the school, I've had the pleasure the last decade or so to direct a specialization that the school has had in maternal, child, reproductive, and sexual health. Many students have come through that specialization, including that in their master's or doctoral degrees here at the school, and that has been wonderful and an important precursor to a new hub on sexual and reproductive justice that the school has just launched. There are many faculty here at the school who are engaged in that hub and the various initiatives, and many students as well. So it is with that interest and background that I happily turn to the reason why we're here, which is to engage in conversation with Dr. Allen and Dean McGovern on clinics to courtrooms, reflecting on 40 years of advocacy for sexual and reproductive justice. Just one last reminder, we will have a really decent Q&A at the end of the conversation. So please enter your comments and questions in the chat, and we will be sure to get to them in the second half. So just to start, given the fact that the session is entitled From Clinic to Courtrooms, and we're here at an educational institution, I really need to first ask both of you, what was it that inspired you to pursue your respective fields in medicine and law? And if there was any awareness at the time of sexual and reproductive health, public health, or not. I'm sure we'll get to that in more detail. But maybe Dr. Allen first.
Sure, I'm happy to start. So that is a question I won't be able to answer in 60 seconds or less. Why did I choose women's health, first of all? When I finished medical school, I was really interested in acute care medicine, spent a lot of time in emergency rooms and ICUs, chest ICU, coronary care unit, medical care unit. And my father passed away while I was an intern here in New York. I was an intern in San Francisco. He was here at St. Luke's Hospital. And he died of a condition that I had been taking care of, seeing many patients with what we called emphysema in those days, chronic obstructive pulmonary disease. He was a 2-pack a day smoker. And if he had been my patient where I was working at San Francisco General, would have called a cardiac arrest, would have intubated him, would have resuscitated him. However, I was at his bedside when he passed away, and there was no code called. And I called his doctor to wanted to know why the resuscitative team was not on its way. And he said something very sobering, that death actually is part of the life experience. And there comes a point that we all pass away, and we should be allowed to do that with respect. So that caused me to ponder why I was doing what I was doing. Why was I resuscitating lives? So I actually took a year off, did radiology, and realized, even though I was being groomed for invasive cardiology, that for me, in order to be fulfilled for the rest of my life as my chosen profession, it couldn't be about mastering a new tool or a new technique, but had to be something that sustained me, and probably had to have a political commitment. So at that point, I realized that there was a need in women's health. when I was of that age, all of the gynecologists were male, without much empathy or understanding of how we feel about our care. So at that point, I actually came back to New York, and as was mentioned, did my OBGYN residency at Jacobi. My first job after that was at Harlem Hospital. This was in the 80s. The AIDS epidemic, we didn't know it was AIDS, it was HTLV3, cocaine, crack, and at Harlem Hospital seeing the ravages of that. We actually published probably the first case of Kaposi sarcoma in pregnancy. So there's substance use, a lifestyle that went along with cocaine and crack, which involved sex trade. And what we realized is that our substance using patients really didn't have the infrastructure, the social infrastructure to be compliant with their prenatal care and desperately needed prenatal care. So what we did at Harlem back in 1982 was we co-located the methadone treatment program with the prenatal program. So I went to the methadone treatment program, and the pregnant patients saw me before they got their methadone. So that was insured drug treatment for that population. Time went on, and I went to Bellevue Hospital several years later. And with the support of the chairperson of that department, realized that this was a need to have a special prenatal program for women who were substance using, chemically dependent. And when you look at that population, not everybody in that population, but what the patients we were seeing needed support with housing, transportation, father of the baby may have been incarcerated. So we had strong wraparound services. And in that clinic, we had a nurse who was the glue. She was there every day. The nurse, I was there once a week. But we realized the importance of having social worker involved in our clinic so that the referrals for domestic violence, referral for residential drug treatment programs. And in doing my work, one day I got a phone call. Someone named Miss McGovern and said to me, I have a client who happens to be your patient. Can I come talk to you? And I didn't hang up the phone. We had a conversation. She came to the clinic. She met me, saw the environment I was working in, and made a proposal. She was saying, my clients are your patients. What she's seeing is that they really don't have access to the same entitlements and the same social service supports as the gay men have who have the same disease. What I was seeing was a prevalence of HIV in women who were developing cervical dysplasia and cervical cancer. And then I'm going to turn it over to you, Terry, because it started with that phone call. I'm very narrow-minded, taking care of patients. And then someone places a cold call to me and says, I have work for you to do.
Well, thank you. I want to say how honored I am to sit between the two of you. I think, you have before you, two folks who have really done incredible work, for justice, really. So I'm very moved to be here. And I will say now, before I answer my question, that Dr. Allen is retiring, and I think, I feel like there are many, many unsung heroes, so many. And so in our way, this is also our tribute and thank you to you for the incredible career that you've had. Really, you keep asking me, why I do what I do, and it's so interesting who you are and why you made the choices you've made. So I think it's really important for our students to have different types of role models and hear about the very complicated paths sometimes we all take, with the commitment, though, to certain basics, including justice. So I guess my story is I always was super aware of injustice. You know, I saw it first in the form of gender injustice growing up, going to Catholic school here in New York. I was irritated by inequity that I saw everywhere. I went on to college, SUNY Albany, and also kind of got involved in various causes and decided the best path would be law school. And I went to Georgetown in 1983. It was pretty grim, I have to say. It was very conservative law school. I felt like we were being trained to, kind of be hired guns. I wasn't very comfortable there. This is a long time ago. The school has probably changed a lot, just to make that disclaimer, but they wouldn't let the gay LGBTQI students have a group. They wouldn't let the reproductive justice group be a group, an officially recognized group, even though we had a mandatory student fee. So I had a lot of questions and I was somewhat unhappy. I didn't find studying the law, it seemed to be all about property. There were pictures of white men that lined the walls. So the way I survived the experience was through work. I first interned for a family court judge, Gladys Kessler, who was an incredible judge, who really understood the racism, the economic, situation that a lot of the women who were being charged with neglect were facing. So I got exposure to, again, racism, sexism. I worked doing investigations because I was in DC in West Virginia in migrant camps. And I saw that there was all this exploitation, but the women in particular, there were no bathrooms, there was nobody dealing with pregnant women. So there was rampant sexual violence. So the kind of intersecting gender, race, however you want to say it now, became very clear to me. And then I went between my second and third year and worked on the border in San Diego, Mexico, and they actually let law students handle misdemeanors. So every morning I would go into these holding cells that were filled with people. And again, the women had really intense issues around pregnancy, around sexual violence, about what had happened to their kids that nobody was really paying attention to. So those experiences all led me, as I was graduating, to decide that the way I could work with women, the women who needed the most legal help, was to be a poverty lawyer. So at that point, there was there still is, it's just been way cut, but there's a federally funded program that is called Legal Services that had offices all throughout the country. You could qualify for civil legal services if you were hugely below the poverty line. So I took a job in a legal services office here in New York City. So that was kind of my path to becoming a lawyer and choosing to be where I was when this all began.
I would imagine landing there somehow led you to picking up the telephone and call Dr. Allen. So to pick up on where her story left off.
Yeah, so it was 1987, and I knew I had friends, gay male friends who had HIV and AIDS, and so I knew something about this epidemic that was hitting the city. And in my office, which was originally in Hell's Kitchen, literally you just saw anybody in the neighborhood who was, poor enough to qualify. And I was supposed to be I was hired to do housing, anti-gentrification work in Hell's Kitchen. Obviously we didn't do so well with that. Anyway, I started to notice that there were some very sick looking women and gay men of color coming in. And then I started to notice my colleagues were saying, I can't take that case, I have children. I don't feel comfortable taking that case. So I took those cases. There was another lawyer who was a fellow from Cleary Gottlieb who also was willing to take the cases, but this was the time when, you know, the receptionist was spraying Lysol after the clients came to see me. The stigma and discrimination was intense. So I started to, some of the folks that I'm describing who had HIV were coming in because they were living in public housing, and while they had kind of fixed the definition for succession for gay couples, like you could take over the apartment in rent control and rent stabilized, nobody had thought about folks living in public housing. So I had a lot of gay men of color who had lived secretly with a partner who died, who were gravely ill and being evicted. And so, you know, horrible things that I saw, that we experienced, being thrown out of offices. But I noticed with the women, there were a number of women coming in that they were coming in because they couldn't qualify for Medicaid, they couldn't qualify for disability. And when you have no money and you're too sick to work and you have children, the next thing that happens is if you're a woman of color, frankly, without resources, the next thing is they come after your kids. So they were coming in for Medicaid, disability, discrimination, but also for help because they were being charged with neglect in many instances. So the first stop would have to be to get them to qualify for Medicaid and disability. And frankly, all of the programs that existed, due to the incredible advocacy of gay men, were, if you had AIDS, there was housing available, you automatically qualified for disability and Medicaid. And just to say, things were horrific for white gay men, right? This was the time when they weren't letting people see their partners. The church was very active, opposing things. So it's not like it was a pretty picture for anyone. And but the gay male community had really mobilized and gotten certain wins and gotten certain things in place. It was just a whole different picture for the patients or the clients that I was seeing. So when you are appealing the denial of disability or Medicaid, you have to get folks' medical records. And so when you get their medical records, you get to see who their doctors are. And I could answer this question for an hour, so I'm going to stop. But a few of the patients, right off the bat, there was the same name of the doctor.
Yeah, so unfortunately, there are not a lot of providers who want to take care of women who are addicted or chemically dependent, maybe homeless. So there are not a lot of us. So I guess that's why it was the single name you were running across. But I do want to say at that time, I don't know, Terry, if you remember these names, but there were women who were active in their fields. Kathy Potler, who was looking at women incarcerated. Wendy Chafkin, who was looking at women on Medicaid who were not allowed into residential drug treatment programs if they were pregnant. Rhonda Copeland, who litigated with Roe, if I recall. So we found each other. You found me, I wasn't looking for you. So one of the points that resonates with me, as physicians, we are really narrow-minded, taking care of the patients in front of us. And I think, Terry and I were talking about this earlier, I think from a legal perspective, it's more circumspect. I don't know if you agree or not, but I wasn't looking for the lawyer, and maybe the lesson to pass on to young physicians is to be cognizant that there are other professions, other disciplines dealing with what you're dealing with. When you think it's hopeless and there's nobody out there thinking like you think, there are.
Yeah. Well, and you sort of just jumped to like the punchline at the end, and I think we definitely want to get to your thoughts going forward about this sort of interdisciplinary collaboration experience, but if maybe you could tell us a bit about the specific one in the SPV Sullivan case and how you collaborated on that.
Yeah, so we started, so I actually really didn't know what to do with all of these clients because what you do is you request a hearing when somebody's been denied disability, and we would go to the hearing, and the decision was very, very sick women, and the decision would come was not credible on level of pain, and in many cases the client was dead before the decision even arrived. And that's where ACT UP got its dead but not disabled signs. If you go back in history and you look at that, it came from those cases. So let me just say a bit about the women, and not all the women, but SPV Sullivan. SP was a young woman who experienced violence in her home. These were extremely vulnerable women, not all of them, but what was happening, what I saw happening was just surreal. They were disappearing before my eyes with no services. Anyway, so we realized, we looked through, collected all these medical records and kept seeing the same thing: HIV positive, not AIDS, HIV positive, not AIDS, HIV positive, not AIDS. And there was this form that you had to fill out called an M11Q, which was the entryway to services, right? And so the M11Qs would say HIV, not AIDS, and then they would not qualify for anything. So there was no way. So I was a lawyer. I went to the floor of ACT UP and asked, were people seeing this? I called Gay Men's Health Crisis. It turned out that there had been some women incarcerated at Bedford, and now it turns out incarcerated women in California were also onto this, saying HIV looks different in us. We're seeing gynecological symptoms. So I kind of heard that and then thought, maybe what these folks are saying is exactly what I'm seeing. So basically, I think around then, that's when I reached out to Dr. Allen to discuss what I thought might be a pattern, right?
Yep.
Yeah. So I called Dr. Allen and we met, and it was really interesting because eventually there were quite a few doctors involved, right?
Yeah.
Because we had clients from all over the place, all over the city. And I asked Dr. Allen, I think in that first meeting, could this be true? Could HIV have a totally different, because how come these women have 2 T cells but not AIDS? How come they're dying and they never get AIDS? Could it be that in women, the manifestations are different? And part of what the activists had said to me is, and I mean the incarcerated women, was that women hadn't been included in all of the original studies to come up with the AIDS definition. Like when there's a new disease, this is where science is not objective, right? This is the biggest lesson that I have carried from this experience. I mean, there were no gynecologists on site in the original studies to look at what was this new disease. So of course you weren't going to capture any gynecological symptoms. So actually it was true. It was true that the definition was pretty much based on a particular population and was being used as the gateway to everything. So I needed to verify that because I'm not a doctor. Right?
But I think we were noticing that an increased incidence of cervical dysplasia in this patient population. So we were doing our research as well. What's association, is what's the correlation? So it was kind of happening in parallel.
Yeah, so there was a ton in these medical records of cervical dysplasia, pelvic inflammatory disease, a lot of aggressive gynecological symptoms that were seen as not related, but they were so prominent that, so I don't remember if I said at that first meeting, do you want to be part of a lawsuit?
Do you think I remember 40 years ago?
Right. I mean, so,
I think my recollection of it, it evolved. It wasn't
Yeah.
really a question.
right.
It was, I need you.
Right. So Dr. Allen really was the perfect partner because Dr. Allen is, as many of the best of us are, very conservative about her judgments. She makes very serious, she looks at the evidence. This is somebody that I trust. I knew would never say, I'm gonna sign on to this if she wasn't 1,000% sure that there was a problem. So that was really important. And so basically, crazily, we found all these plaintiffs. Just to give you again a little taste of the times, it was so scary that we had to proceed under initials. We had to do this specific type of legal proceeding because it wasn't safe for these people to be identified in the lawsuit. So it's SPV Sullivan because we couldn't say the woman's name. And, that required finding people, homeless people. It required a lot of, I think I worked with your staff to actually get folks to sign the papers and do it. And we filed a lawsuit with Dr. Allen's help in October 1st of 1990. And when we filed the lawsuit, we also held the first demonstration of HIV positive women in front of Health and Human Services in DC. So I filed in the morning and then got on the bus. And if you ever are of history, if you're interested in the history of women HIV, Iris De La Cruz was at that demonstration, Katrina Haslip, like some of the women who had the guts to actually say, I am a woman, I am heterosexual, I have HIV. Some of those women who are so brave, long dead, were at that demonstration. And if you watch the footage, they talk about, this surreal situation where they're entirely ill and they're being told they don't have AIDS. And, so it was quite something. And so, of course, the government came back with 1,000, they littered us with, opposing papers. So the partnership with the physicians and you in the lead was really important. We had to keep answering these legal papers, right?
So what was that like for you? Because you started off saying like you're a clinician, you would have like this narrow focus on treating the sick patients in front of you, and then now you're engaging in this very different set of
So it was gratifying and refreshing because I have had contacts up until then, as I said, with progressive women lawyers and doctors, that there is something that can be done. And with Terry's energy, and who I forgot, Lynn Paltrow.
Oh, yeah.
He was working with
association for young women.
yeah, women who were addicted and were being incarcerated. So I was lucky enough to be surrounded with acquaintances who were active in their areas. So it wasn't that foreign to me. And as I said, you sit, you see your patients, you make your assessments and plans, and you come up with the treatments, but you really are dependent on a broader circle of acquaintances and professionals to take your experiences one step further. So I welcomed it. I welcomed the relationship with Terry. She taught me so much. I don't know, I don't think I have written as many amicus briefs as I had back in those days. And I think it's very important for us to be connected with someone who can translate your experiences. I'm not a lawyer. I can't mount a legal argument. I can't convince you to do something you don't want to do and have you think that it was your idea in the first place, which is what lawyers do. They just take you down the garden pathway and you nod your head. So to have someone who can take a concrete experience, translate it into an argument that actually is where you wanted to go with the first place. It really is refreshing, exhilarating, and I'm thankful that people like you exist.
So did you want to add something to that, or?
I just wanted to say that I think, I want to say that I think also for the patients, clients, I call them, patients, she calls them. It was really, really we did a lot of work to explain why they were experiencing what they were experiencing. In other words, there are discriminatory criteria, right? That is the reason you've been denied. I think with HIV, there was so much shame and particularly with children involved, and most of the women never knew that they were positive, and because nobody thought they might be positive. So there was all this stuff in the records, which was all about, frankly, racism, sexism, all kinds of opportunities were missed with women. And I think what we did is to make sure we explained to them what happened, why were they denied? And I think it really had a transformative effect on them. And so while I'm saying we had to run all over town, I just had this image of being right over there, getting this client on the street to sign papers. They were actually very happy to be able to fight and to be able to say, actually understand that it wasn't their fault.
So there's a difference between someone suffering this experience, having this experience and thinking it's bureaucracy. It's, well, I'm poor and I just don't have access like other people have.
Right.
I'm not sick enough. But then to really understand that structurally or systemically, sort of the deck is stacked against them, that they're really, yeah. So I wonder, I guess if we were to fast forward, clearly the case was successful, won, right? Benefits, then eligibility, right, for Social Security benefits,
This was
Medicaid.
expanded, they redid it. Dr. Allen helped us rewrite the criteria. Do you remember that meeting? Very long. So
The criteria for the
disability,
presentation.
yeah, the new disability criteria.
So that then they would then qualify.
Yeah.
So I wonder if we then jump to, okay, this was experience, you described it as gratifying, right? And it's not necessarily something you would have on your own
Absolutely not.
gone into.
Yeah.
I understand that you engaged in other advocacy types of activities, like, for example, the mandatory testing. I imagine this experience sort of changed your scope of your work as a physician?
Didn't really change my scope, but it really opened the door to it is possible to do more than just see your patient in the exam room. So what you're referring to, we were testing women for HIV, postpartum women. And we also concurrently was encouraging breastfeeding. Breastfeeding is very important with bonding. So my patients were coming from disorganized lives, maybe have had previous children and with ACS that have been taken away from them in foster care. One of the things that we agreed upon at the beginning of the prenatal course is, why are you here? Why am I here? For you to be drug-free when you deliver, for your child to be drug-free and not suffering from withdrawal symptoms or absence symptoms, and for you to go home as a unified dyad. And part of encouraging that unified dyad and the bonding and the parenting, because a lot of our patients, it's intergenerational substance use and no real role model for parenting. And those of you who are parents, it's not really that easy, especially with your first child, the first several weeks. So we encourage breastfeeding. So here we have a woman. We've tested her. She's HIV positive. We're encouraging breastfeeding, and she doesn't get her HIV result until 3 weeks later or 4 weeks later. And there's HIV in the breast milk. So, having determined that that really is putting children at risk, as well as the mother at risk, we challenged the New York State Department of Health. Why does it take 3 weeks or 4 weeks to get the results? Why are we putting the child in danger? You want to tell the rest of that story?
Well, just, so imagine like in this kind of time period, you went from having to fight to get the government and others to acknowledge that women had AIDS. It just looked different. And by the way, when they they expanded the HIV criteria for disability, but they also expanded the AIDS definition, added cervical cancer, added, that was a massive grassroots effort, right? And I think the numbers of women of color with AIDS went up over 40% after that. So just again, back to science not being unbiased. But it was kind of this crazy thing. The next thing that got everybody's attention was, there are babies being born. There's a blind survey of newborn seroprevalence, and so somebody knows that these babies are positive and nobody's doing anything about it. And so they unblinded, the only state in the country unblinded the seroprevalence study. And I was aware that there was no requirement that they even offer HIV testing to pregnant women who came in. I was aware that nobody was screening women, talking to them about HIV. So how come we're skipping those steps and we're gonna suddenly, because what HIV positive baby tells you is that the mother's positive at that point, even without medication. I think 2/3 chance that the baby would convert. So what the unblinding of the study was really mandatory testing of pregnant women. Again, from my view, without having ever offered them a test in any instances. So this became a totally politicized, crazy conversation, which made my head spin because I didn't understand how we went from ignoring women to assuming they wouldn't do whatever possible thing they could do to avoid their kid being positive, right? So you just described what you were seeing from your perspective. I start getting these clients coming in who were breastfeeding for 4 weeks, 3 weeks, and then got a letter saying they were positive. So we actually went and got a temporary restraining order because you're not, at least in life as it was, you can't have a kind of bodily intrusion without there being some very serious medical reason for it. And here they were, testing women without their consent and weren't actually doing anything about it. So once again, when I had these clients, I called Dr. Allen and said, could this be true? And that was way scarier. I think the HIV case, like we were kind of, but this put you
Knowingly infecting newborn children.
right. But this put you also, this was something that was very risky for you. Because not only did you agree to, be a medical expert on the court part, but I also asked if you would confirm to the New York Times that this in fact was happening. And you did.
So it was in the New York Times that came out on 4 a.m. one morning, and the State Department of Health was interviewing me at 1 p.m. in the afternoon about what I had stated, that we are actually putting newborns at risk, knowingly, if we know what their HIV status was, knowingly infected children. And we wound up actually turning the turnaround time, which was like 48 hours. And it was possible, first it was not possible in the lab to get the results in a short period of time, but they figured out a way. But it was for me, it was very interesting to see the time frame from 4 a.m. when the presses rolled to me being interviewed by the State Department of Health that afternoon. It was a very sensitive issue, I guess.
Yeah.
You think?
So, I mean, but, honestly, bravery, we fixed some big problems, right? And we were able to fix them because you were brave enough to step forward, because without a medical expert, without you confirming that, they were saying it wasn't true.
So I think one of the take-home messages, you described me as being very conservative and
Not in your
meticulous.
politics, I mean, right? Just in
Yeah,
your
yeah.
evidence.
I would not call myself conservative, but in terms of my work, and Terry is the same way. I think the driving force in her effectiveness is her diligence in collecting the data, verifying the data before she goes public with the data, interviewing as many people as she can, patients as well as physicians. And the lessons I've learned through my relationships with Terry and other activists, lawyers, physicians, is that you can actually change rules, laws, opinions, if you have your facts in a row. It's kind of like Nancy Pelosi. She had her votes lined up before she ever took anything to the floor. You have your data lined up. You present your argument in a dispassionate, very objective way. These are the facts. The sun rises in the east. You cannot contest it.
On that note, and maybe just moving us to present day, right? Because we could still have facts, we can still have the data as researchers and scientists, we kind of eat, sleep, and breathe that. But then you have folks who say, well, numbers can be, manipulated and analyzed differently. And then, we are in a moment, have been for a bit of, excuse me, even one, excuse me, questioning what are facts in the first place,
Well,
right?
Didn't we stop fact checking in one of these social media platforms?
Right.
Yeah.
Yeah, for sure. But what, I guess my question is, what does that mean for professionals who are serving patients, clients, serving the public, and want to advocate, speak up, evidence-based, right? On issues that come up. You've described these incredible issues around HIV/AIDS, and there are numerous, issues that we would want to point to the data and then say, based on these data, we really think we should change course or enact policies or sort of not pursue certain policies. And folks feel very, I think at this moment, vulnerable and scared to do that, even with the facts. So
So I'll start off with
Yeah.
Terry, because I'll start off from the scientific medical arena. There needs to be oversight, not necessarily regulatory oversight, of research that's being done, whether it's lung cancer, HIV infection, that all populations are included. So as you see research coming out, there are questions that should be asked. Are women included in the trial? Are the different racial and ethnic groups included in the trial with sufficient power that there's statistical significance? And the other thing I have posted on my kitchen cabinet that says resistance with resilience. There's some people you cannot have a cohesive, logical, intelligent conversation with. Those are the zealots. But there are other people that you can actually have a discourse with that are receptive to logic and intelligence. So we're not a homogeneous society with just ideologues on either side of the debate. But you have to believe, so in my retirement, I'm very cognizant of how important it is for me to pass the baton on to someone who is energetic, optimistic, because optimism is a choice, and can run faster than I can, and can complete the marathon better than I can. And it's resilience. And you always need to have an iota of resistance as well. And you need leaders. You have to identify those people who are receptive to change, receptive to different arguments. And the optimism is truly important. You can never give up. You can never throw in the towel. But you do need to have your ducks in a row. And you have to galvanize those of like mind and life thoughts.
So we're obviously in an incredible moment, right? So just to say, I mean, my head is spinning because we have, first of all, it is this whole process now where all kinds of funding is being cut. The current administration, doesn't want DEI, doesn't, is against gender ideology. There's a long list, and of course, we know really important grants, research are being stopped. I used to teach a class at Mailman with an environmental scientist, and it was really interesting. Again, science, law, and she once said in a class, the NIH is pretty good. Like they include people of color in trials. And I said, well, you do know that's because we had to sue. So just to say that you said it in my intro, I saw women who had AIDS who were being turned away from trials unless they got sterilized. And this led me to the discovery that there was a 1977 FDA guideline that said women of childbearing potential shouldn't be in the early phase of clinical trials. So at the same time, activists all over the country, scientists, public health people were saying there aren't significant enough numbers of people of color, of women in NIH trials for AIDS and HIV, but for everything, right? So it was a concentrated strategic effort to get federal regulations that required the inclusion of communities of color, of women in trials. And in fact, I was on some task force in 1995, National AIDS Task Force, or it had a different name, but we were able to change the federal regulation so that you could use a clinical hold to stop a trial if women were excluded. Now, when you're reading in the paper and hearing that the current administration is getting rid of anything, uses the word gender, anything that talks about diversity, communities of color, you have to really think about the impact on science. So these concepts and these things that were surfaced in our joint work are more relevant today than ever. And in a weird way, what you said, which is if you're going to take stuff on against the federal government or anybody, you better be super prepared and you better make sure you're completely 1,000% accurate. Yeah. If they've stopped all these surveys, which give us data on what's happening, we already know that they were insufficient as they were. They didn't have enough detail, but now they've stopped them. To some extent, we're being stopped from the science that will address the issues and from tracking the outcomes. And if in fact it's no longer required because it's DEI, that there be significant numbers of women, people of color, we're going to be back to the situation of not knowing how drugs work in populations that are taking them. So, sorry.
No.
Yeah, but I think the importance of this webinar is to reflect back on our history.
Right.
But there's a history of the country.
Right.
So we're going back to Jim Crow, or even before then. But the United States has been challenged with fascism. And we bounced back. So this is where the optimism comes in, that we've been challenged before, the democracy has been challenged. There needs to be optimism that we can overcome this and change this. And we need to identify those with the energy, the resilience to resist, we need to support them somehow. I don't know if I have to get on my Airbirds or my
Yeah.
basketball sneakers and get out there.
Or like retirement, but
But I think we have to believe that this will not be our future. We have to fight back. We have to encourage those who have the discipline, the insight, and the wherewithal to know how
Exactly.
to do it.
so what Dean McGovern said was sort of on my mind as you were speaking, previously around the resistance and resilience, right? And making sure you have all your ducks in a row and the data. And then you said what was on my mind, which was, but if the data we're hampered in our ability to have the data, collect the data, then it's this sort of vicious cycle where we're just not, we could have the resistance intention and be resilient, but we're lacking in maybe some critical tools. And I want to go to your optimism piece because I have been really impressed and heartened to see all of the resistance and resilience efforts that have been made in terms of folks who are securing data, retrieving,
Yeah.
rescuing data, storing them in repositories so that we can be resistant and resilient.
Mhm.
And I think it's been inspiring and at the same time a little, more than just a little overwhelming. But I see that it has been happening. And here at our school, we've been organizing in an ad hoc way to just see how we can access these data sources, these movements, if you will, engage with them and try to do so collectively so that we can, continue to meet the goals and objectives of public health. So I feel like we're sort of building the train while we're on it, right? But I'm trying to hold on to that optimism and I am seeing, efforts of resistance.
Everywhere.
Yeah.
Everywhere. I mean, I am actually very hopeful. This is not at all. I think that we need to do a better job, though, of describing if the average person doesn't know when the administration is taking on DEI, they read these things. We need them to understand the connections, right? Why is it important that there are people of color in trials? Why is it important that women are in trials? Like, I think we have a role also in translating what's not just resisting it and figuring out ways to still do our work, but we also have a responsibility to make people understand that this is really serious.
The implications.
Yeah, exactly. And I do think, we've never, in all the places abortion is illegal, people are incredible, right? People do the work. They just don't let people, we see that here in the city. We see it here at CUNY. Our students are doing all of the most kind of complicated types of public health work. I think these same strategies that we've unearthed here are really, really continue to be really important. And I agree with you. I think all is not lost at all, but we need to name what's happening and we need to use our expertise to help the public understand.
The other thing that is important is money. So as the federal funds are being pulled back, what's going to replace them? And we're in a capitalist society and there's an opposition to capitalism. But as someone told my son, who's a painter, what you earn the money for is so you can have a studio, so you can paint. So it's a circle. We need the philanthropists, those with independent money, Annie Gunn in the art world. Mike Bloomberg has been a real supporter of public health to get the message to the philanthropists so that we can do our work. So we can do our research. The email that came through last night, there's an NIH grant going through Columbia around maternal health and well-being, maternal mortality and morbidity. Well, the grant was just ended yesterday. But we still need to continue that work, and we're going to need financing, whether it's Robinhood, Bloomberg, or we really need those connections, because you can't paint without a studio. You can't do research without a lab, and you can't do your work without funding either.
And if we take the historical view, this is a moment,
Yeah.
right?
for sure.
And it's weathering the storm in the moment.
Absolutely.
I think that's a great point at which to maybe pivot to questions that may have come in the chat. But maybe before we get to that, I'd love it if each of you could maybe just reflect on, we talked primarily about this collaboration that came about, not sort of a priori with a plan when you landed in New York after law school, or you were treating pregnant women in Harlem Hospital, but because the circumstances, the social circumstances and the public health crisis brought you together. And it ended up being this collaboration between, you know, a clinical expert and a legal expert, right? So maybe if you could talk a little bit, thinking about the moment we're in now, maybe other types of collaborations that you think other sectors or professionals, to include, you know, the medical sphere and the legal sphere. We're here in public health, which I think permeates into everything. You know, we all oftentimes describe public health as being about everything. But what are your thoughts about maybe other combinations of sectoral collaborations that would be helpful in the moment?
Yeah, I do. I'll give you a minute. So I think, I think first of all, there's so many AIDS histories around, you won't find what you heard today in them. So I think this whole issue of what is history, who's included in history, whose history, at the UN, the number one thing being said to folks fighting for human rights standards around women and girls is that these are Western concepts, right? These are Western concepts. As I said at the UN, I had a very hard time believing that it was, Socrates or John Locke who came up with the concept of justice and human rights. These concepts have existed in tribes, in all kinds of cultures forever and ever. So the problem is the history isn't there. The history of women is often so untold. And just like with my clients, the actual history unlocks agency for people. You learn that your ancestors went through way worse and fought. If that's documented, if it's not documented, right? So I think collaborations with every form of knowledge management, history management, and obviously also artists, right? How do we, even again, going back to the last couple of days at the UN, people don't understand when they're saying gender ideology. Like, we need artists to actually explain what is happening so that it moves people, they understand it. We also need joy. And one of the things about the untold histories, whether it's the story of the women we worked with, is I always said there was so much joyful resistance, right? It's in the history you see that people have found ways in way worse moments than this to resist and do so creatively. So I think we need to do a way better job, and we need to do a way better job of documenting what we have seen and experienced, and also unearthing these histories and taking on these narratives like human rights is a Western concept with history.
I don't know if I can ask that, but I definitely agree. There is probably not a discipline that it could be excluded from collaboration.
Yeah.
whether you're writing poetry,
Right, exactly.
painting, dancing. Um, our lives are all political. And we are subject to politics. And if you're a woman, if you're of color, if you're an immigrant, you're marginalized. And your experience, whether your experience is as a short order cook at the diner on the corner, or as the senior vice president of the largest municipal hospital system in the country, there are affronts. And if we don't share that affront or talk about the affront or publicize the affront, I had a gentleman come into my office yesterday, an African-American male physician. And I think he just wanted to talk. Have you experienced this? Am I the only one? And he's not. So communication is key. How we communicate visually, auditorily, the written word. If you have that gift and that talent, and you're experiencing an affront, I'll call it, an oppression, you have an obligation to share. I stand on someone else's shoulders, and I think the feeling among many of my contemporaries is that we owe it to our ancestors to be vocal and verbal and to share our experiences, and not just share the experience. The experiences, you bring the tribe together, there's cohesiveness, there's strength in numbers, but to affect change. So I can tell the story, Terry can affect the change. It's like a chain reaction. We all have a role to play.
And I think I would just add being more maybe focused in public health topics that I've engaged in research, maybe myself or maybe others that I've read about, been aware of. Colleagues in education, I'm thinking right now, we just heard last night, maybe came out the cuts to the Federal Department of Education, right? So colleagues in education, in social work, that's been mentioned here before, obviously medicine, health and the law, journalism.
Yes.
As well as law enforcement, right? I have a project in collaboration with the medical examiner's office and just all of these, the potential for the knowledge and, different viewpoints. Dr. Allen, when you mentioned, again, being optimistic, and so many folks in these various sectors are working, around trying to improve very challenging and negative situations. Public health tends to have such a negative focus, like disparities, inequities, but they're doing the work, right? We're all doing the work, and we wouldn't be doing it if we didn't think fundamentally that there was a potential for improvement. But that collaboration, when folks can kind of look at the same issue with different lenses and different strengths and skill set, I think, hopefully that comes across to students in our programs as well, that they don't feel they have to solve these problems by themselves, nor necessarily can anybody.
And actually often, the medical examiner's office was hugely helpful. They showed us how many women had died without AIDS, with HIV. So my experience is there's generally good people around, and you need to ask. You need to ask them, will you collaborate? Will you help me here? In my experience, most people say yes. So I think we have to get more comfortable doing that, because it's never going to be just one discipline that is, particularly in this environment. We need a lot of disciplines coming together, a lot of different lenses. Yeah.
It's great. So I think we might be able to switch to a couple of questions, pardon me, from the chats. And my computer has to look up first. Thank you. Okay, so from one of the folks in the audience, we have the following. New York is often seen as a stronghold for sexual and reproductive health in the US, with many traveling out of state to receive care in New York City or New York State, right, coming to us. From your experiences, what advice would you give to public health practitioners in New York to protect SRJ, sexual and reproductive justice, within our state, while also supporting colleagues working in more conservative states or climates?
What we can do.
Yeah.
To support
What advice would you give public health practitioners here, right?
in New York City.
Given that we are a destination, right, for
Yes.
folks who are coming from other states. And yet we still know there are colleagues, right, in other states that are struggling under very restrictive environments.
So at New York Health and Hospitals, we are actually providing medical abortions in the first trimesters, and we go up to the mid-trimester as well. We're also providing telehealth abortion services over the telephone. So we actually have provided services, medications to patients who are out of state. We have legal counsel with an H&H so that our providers are protected. But the services, I don't know if it's easier to do it within an institution as opposed to your private practice. But within our institution, we're able to provide those services in New York City with legal protection as well. So it's set up very cautiously by our general counsel, what we can do and what we can't do. But we do offer virtual services for medication abortions, and we go pretty much up to mid-trimester.
And in terms of support for folks, colleagues outside of the state, have you or others at H&H or that you're aware of in the health department been approached by, like, in terms of guidance, support, collegial?
So my answer is going to be that in New York City, we have the Center of Reproductive Rights who litigate these situations and litigate outside of New York City as well. My advice would be, and Terry, welcome your ideas. You can either be that person who steps out and is willing to be the test case with the support of the Center of Reproductive Rights. It's a law firm dedicated to reproductive rights. I think the caution is very real. We do know providers who've been killed for providing the services, and below that, we know what's happening in Texas, that they're being prosecuted. So it cannot be done haphazardly. It really has to be done with the protections, eyes wide open, access to legal representation. And as I said, in New York, we are providing the services, but clear guidance and guardrails by our lawyers.
Yeah,
I was just saying, from a legal perspective, we do know, though, that there is a test case, right? A New York provider has, and you probably know more about it than me in terms of the request for extradition.
yeah, so I mean, I think, so just to answer the first part, New York State, and this is partially some of the work of this school, the NYCLU has a really good law, has a lot of protection for people providing reproductive health, and has tried to protect against this situation of being prosecuted for laws in a different state, right? So I think we are one of the most protective states, if you want to use that language. That being said, it's kind of wild out there. So they will continue to try to prosecute doctors even in good states. So the state has acted quickly to block the extradition of this physician. But I think, the other important thing is we do a lot of work. You do a lot of work holding up, investigating what's happening in the banned states, right? Trying to tell the stories of the fact that, pregnant people who are miscarrying in some cases are being turned away from clinic after clinic, emergency room after emergency room. I think we can play a very important role in, kind of helping, really share the data that's emerging about increasing sepsis rates, all kinds of bad things are happening. So I think, the folks in the state, and again, incredible people are so up against it, we can really play a very important role in helping with our research, with sharing the data, taking their lead on what's helpful always, but I think it's very, very important.
Right, and that does remind me that not only this project that you're referring to is being led by Wendy Chapkin, who you mentioned has been longstanding, OBGYN, epidemiologist, advocate and activist for sexual reproductive health and justice. And yeah, the data that's been coming in from physicians in 4 banned states who are theoretically ancillary to sort of straight on OBGYN care, like emergency medicine physicians and fertility specialists, who oftentimes are confronted with patients in some medical crisis who have very wanted pregnancies and are struggling with the restrictions of the states that they're in providing care in that regard that may require, terminations and reporting very, very problematic, troubling outcomes and not being able to even provide the standard of care. So yeah, that will continue for sure to come out. All right, so another question specifically to Dean McGovern. During your litigating experiences, how do you balance centering the voices, expertise of underserved community members while also maintaining their confidentiality around such a stigmatizing topic? I guess in this case, the HIV/AIDS, right? You mentioned only referring to them by their initials, but what other considerations did you have?
This is a great question. Thank you. So, I really do see lawyers as kind of technical experts, right? Nobody needs somebody to be their voice. They need your technical expertise to explain to them why precisely they're in this horrific situation. So, very serious to me from the beginning was what I called back then turning on the lights for the clients about the structural discrimination that they were experiencing. This was so profound when I saw the impact on them, to understand this wasn't their fault. They had shown up at the hospital over and over. Nobody offered them a test. Nobody told them that they were at risk. It wasn't their fault their kid had HIV, right? So we actually developed a whole serious set of teachings and ultimately a class named after one of the women who was in the lawsuit, Katrina Haslett. They called it the Katrina Haslett Law Technical Assistance Program. But we really took seriously teaching the clients about the systems that were now really hurting them. And so because we invested in sharing that knowledge, how would they know that, right? It was such a big amount of work to figure out who they'd studied and, right? So the idea that so we actually made sure that they understood, and then therefore they were really powerful when they talked to the press. So you asked about other sectors. I would say, along with Dr. Allen, there are also a number of very brave women of color journalists who covered this. And they spoke to the clients. They went to their homes. And these women were able to say, this is what happened and this is why. And so I think, we very much saw them as the lead. And in fact, if you watch the footage, if you're really interested in this, watch the footage from the 1990 demonstration on October 1st when we filed the lawsuit, because you hear the women talking about this. So I think really understanding your role as you have information to share so that they can represent themselves in their lives, right? Rather than talking for them.
And it almost seems like it makes this notion of maintaining confidentiality moot, because when they fully understood what was going on, they had voices, but now were empowered to speak up in whatever way, right?
Yeah.
Protesting or
Yeah, exactly.
advocacy or.
I wanted to just say that, of course, there were some clients that were vulnerable, too scared, and they, of course, didn't want to. Maybe they went to the trainings, but they didn't want to speak. So everything about it was about their choice. But I think it's absolutely true that as they learned there were a community, this also meant that they met other people in the same boat. And, it became more what I said then and will say now, joyful resistance, right? We may be being discriminated against, this may be outrageous, but we're in it together and we're fighting. So I think the other thing I wanted to say is that when I first tried to get a little grant to have this what we call the technical assistance program, that one particular philanthropist said, "Oh, this is ridiculous. Why would women with HIV who have kids come to a class? Nobody's going to come to a class." And we had like a waiting list of like 50 names, right? The women showed up. It was incredible, right? So that's just totally, there are all of these preconceived notions that are deeply problematic. It was really important.
We have a few more minutes. I'd love to get to a final question in the chat, and then just quick some final thoughts. For Dr. Allen, we have a question here. Advocacy work in this area can be incredibly mentally and emotionally taxing, particularly in this political environment. How can we maintain momentum and resilience as individuals who want to continue in this work? Now, I know you spoke a little bit already about resilience and optimism, but I wonder if coming from a medical background, we're here in public health, and part of public health is advocacy, evidence-based advocacy, engaging with communities, etc. I wonder if you would want to speak a little bit more to folks in other health fields like medicine, nursing, etc., who may not have in their formal training advocacy.
That's an interesting question. So there's advocacy and there's also stress mitigation. I don't think there's formal, maybe a formal training for advocacy, but it surrounds us, especially in this city. But I think in this city, it's much easier than we realize to find access to people who think like you and are motivated by the same things you are. And even as simple as going on. So when I was retiring and figuring out what to do when I retired, I went online. Doctors Without Borders. I'm a little too old for that, to go into a war zone. The Red Cross. News School. There was in the news coverage yesterday of the defunding of Columbia University and hundreds of millions of dollars. They interviewed an older gentleman who was a student at Columbia auditing classes. I think in this city, as in no other city, you can find what you want. You can probably Google advocacy zip code 10002 and there's something there. I think what you refer to is burnout and going up against the forces, and how do you preserve yourself, your tenacity? And that's really a much more difficult question, because you can fight and fight and fight and fight. How do you build internal resilience so you can get up the next morning and do the same thing? So there's A lot of things we're looking at in health and hospitals is self-awareness, self-help, self-preservation, access to support systems. So that it's not stigmatizing when you become burnt out, you know when to step back. But how do you build internal resilience? I think our behavioral health specialists are looking at that, and that's a question that's yet not totally answered. We all can't go to a beach in Puerto Rico. Or read speech.
Right.
But we have to take time out for ourselves. If we're going to sustain ourselves over a long period of time in this fight, there's nothing wrong with taking time off.
And I would suggest that even the experience of engaging with others in advocacy can be, sustaining.
If you're the sole person that's going to beat you down, it's really important to identify, as we said earlier, the group, the affinity group. Because we are not alone. We have 8.5 million people in this city. And as I said, the internet, there's so much in this city that the city offers so much to all of us, options, and more so I did. Not that I've ever been to Pocatello, Idaho, but I would think more of New York City than in the middle of the country. What I really am concerned about is the middle part of the country, the farmers, who are being subjected to the same things. While Trump is going after the marginalized, he's also hurting the Great Plains, the farmers, etc., who depend on imports and exports, exporting their goods, as well as importing the lumber, etc., to build it.
So I think in just the last couple minutes we have, I'd like to just turn it back to you both. And we've covered a lot of ground. And so maybe if there's just maybe one key message you'd like to leave us with, whether it has to do with the experiences you shared back in the period of HIV/AIDS or the current moment. But if there's one thing you'd like to highlight most, if you want to, would you like to?
Well, I just really think activism. It takes a little bit of energy to get out there and act on your beliefs, but you have to know that you're not the only one, and to build the bonds and the collaborations. Collaborate. We can't do anything by ourselves. No man is an island. No woman is an island. To affect change, build the coalitions, know your data, and reach out to others to support you. I think for me, it's all collaboration.
Yeah, I mean, I think, one very exciting thing, not to plug us, but that's going on at the school is developing this new sexual reproductive justice concentration. And one component of that we're calling leadership, but it's really going to take a very complicated look at all of these issues we've been talking about, which is how do you survive in these very complicated environments? How can you be strategic and effective in very complicated environments? And I would say, looking back on my career, it has been really important to have people outside of the institution I'm in that I trust, that I collaborate with, that I can ask. I'm in this situation right now. I could do ABC. Let's talk through what I do. And let's face it, whether it's you way back when, there is risk to being an advocate, to doing this work. And I think we keep hearing this theme of be prepared, be smart. If you're going to take things on, you have to be over prepared. And that goes for your strategic decision making. When you're gonna question something, how you're gonna question something. So I think but ultimately then you build this community that are often in different fields that are also willing to do the hard thing, but want to do it really smartly. That ends up being, I would say my relationship with Dr. Allen, our collaboration has been one of the great collaborations of my life. So there's great joy in finding folks and who are out of your specific area and figuring out ways to change the world together, right?
Community is so important.
Exactly.
It really is. And I do have to say, Terry had an influence, when we went to Washington DC to testify before the House Ways and Means Committee. My daughter, who's now over 40, was 12 at the time and went with us to testify. And I think, even though she was 12, I think it had an impression upon her. As my mother always said, you never know who's watching. You never know who's watching you. So every day you are an example for someone. You may not know who. But we have a responsibility to be aware of. We are role models, even if we're just in the grocery store.
Thank you. Well, on that note, I would really like to thank our guests, Dr. Machelle Allen and Dean Terry McGovern, on behalf of the CUNY School of Public Health and the Sexual Reproductive Justice Hub. I think, I thank you on behalf of, I think, everyone in the field for your commitment to and passionate work in advancing social justice and sexual and reproductive health. And I think, you've just shared with us an incredible example of multiple successes that have resulted from interdisciplinary collaboration such as yours. Thank you so much.
Thank
Thank
you.
you.
Thank you.